Hello and welcome to this King's Fund online event on changing behaviours, what is available and what works. My name is Dan Wellings and I'm a Senior Fellow here at the King's Fund, and I've got a distinguished panel of experts in this area that we're going to hear from. The event lasts about an hour. I will be asking a few questions to really set some context. What are we talking about here? What are the behaviours we're looking to change? What do we know already? But we want this to be as helpful and practical as possible for you, so hopefully you could see a box at the bottom of your screen. Please do send questions in. We'll try and answer as many as we possibly can. We'll try and group some of the key themes and try and get some of the panel to address some of those. We're very happy this to be sponsored by Seqirus, who have been doing some work on this around flu vaccination. And what I'm really keen to do today is really think about what can people there who are listening in learn from this event. So, to do that, we're going to hear from our panel. So rather than me introducing you, I'm going to go around the panel one by one, and if you can tell me a bit about your expertise, your name, and where you work. So Katherine, if we start with you.
Thanks, Dan. I'm Katherine Brown. I'm Professor of Health Psychology applied to Public Health at Coventry University. I've been working for around 18 years in the field of developing and evaluating behaviour change interventions. Primarily, they've been focused on preventive public health type behaviours. And I've also worked for the last 8 years directly in Public Health Warwickshire, so with colleagues in that context and setting, and understanding more about how to change behaviour within the system as well as the behaviour of people.
Great, thanks Katherine. Sam.
Hi, so my name's Sam Haskell. I'm the Prevention Lead at the Department of Health and Social Care. In my interest in behaviour change, it comes through the work we've been doing on prevention as part of the Secretary of State's prevention priority, which splits into two main areas. It's first about preventing health problems in the first place, and then secondly, if you have a condition, about supporting you to live really well in the community. We published a prevention vision last year in November, and then more recently the Green Paper back in July, which I'm looking forward to talking about today.
Great, thank you Sam. Richard.
Hi, I'm Rick Fordham. I'm from the University of East Anglia. I'm a professor in public health economics, which is a combination between public health, subject matter and economics. So by background I'm a health economist, have been a health economist for over 30 years. My interests lie in looking at improving NHS performance and effectiveness. We do lots of evaluations of different interventions in public health. And I also run and direct a consultancy group called Health Economics Consulting, who carried out the piece of work on vaccination incentivisation recently with Seqirus to see what was making people take up the vaccinations for flu or not, as the case may be. And we looked into a lot of other statistics as well from Public Health England and the like. So that's my role in this, not as a specialist in flu vaccination per se.
Great, thanks. And Tim.
Hello, I'm Tim Chadbourne. I'm Head of Behavioural Insights and Evaluation Lead at Public Health England. I've been working in sort of the areas of health and public health for almost 25 years now, both nationally and a little bit internationally. And I came into Public Health England when it was set up in April 2013, and to set up this Behavioural Insights team within public health and to think through what does that look like, what should it do, and to link in with other organisations about trying to embed behavioural science in public health. I'm part of a network across government Behavioural Insights Network, and then also working across organisations, with many organisations in the public health space.
Great, thank you. So just to start with, really for me, this area of kind of behaviour change or behavioural insights or behaviour science, I suppose I just wanted to ask, what is it? What are we talking about here? I don't know, Katherine, if you could give us a bit of background. There's these different terms. What do they mean? What's this field? How do we describe it?
Sure. So I think there's a bit of a distinction to be made between, so behavioural sciences is perhaps the broader description of everything that we're talking about here. Approaches that are commonly used, behaviour change typically has come out of sort of social psychology, health psychology, and we're typically talking about understanding things that are relevant to the psychology of the human being and what drives the behaviour at that particular level. When we're looking more from a behavioural insights perspective, we might be trying to understand more about what's going on in the environment that affects behaviour.
Okay.
But at the heart of all of it, it's about understanding the range of factors that drive human behaviour.
Great. Okay. From other people, Tim, similar in terms of that interpretation of what you see your role as?
Yeah, I think it's been really interesting, and I want to kind of direct people to the National Behavioural and Social Science Strategy for Public Health that we published last year, with a range of different organisations, like I said, with funders, with professional societies, with some of the statutory bodies involved in this area. It's a very collaborative piece of work. So do look up, Google sort of Behavioural and Social Science Strategy, Public Health, you'll find it. What we're trying to do there is to really sort of set out what some of these things are for people. And we included the social sciences to make it even broader and even more complex. But I think, exactly right, I think people are very familiar with aspects of nudge and behavioural insights. That's, excuse me, that's quite a common theme across the sector at the moment, I think. And also for a long time we've had health psychology, social psychology working in this area. So trying to understand how these things sort of fit together has been really helpful. One of the models I think is very helpful for people. Many people might have heard of it on, who are in the audience. Is a COM-B model, which stands for capability, opportunity, and motivation.
Okay.
Which are drivers of behaviour.
Yep.
And it's thinking about kind of the system in which behaviours occur, and how those things influence. And again, as Katherine was saying, they're kind of more internal influences on our behaviour and the external influences and cues from the environment that drive our behaviour, sometimes more than we appreciate.
Okay, we'll come back to that. That's an interesting point in terms of the appreciate. So, I mean, the behaviours, we're talking about behaviours in the sort of abstract. What do we mean? What do we mean by behaviour? So, Richard, what would you say when we're talking about behaviour? What do we actually mean by that?
Well, it means different things to different social scientists, but to economists it means trying to find, it's essentially we talk about demand in economics, and it's really trying to satisfy a need in order to satisfy a feeling of a feeling that you want to try and satisfy something that you're trying to maximise in terms of your well-being or your life. So it's quite complicated in public health because public health relies on people not only doing things for themselves, but also doing things for other people. And the concept of public health is a collective notion that people are making choices not only for themselves but for others as well. Or the implication is if they are making a choice about, say, having a vaccination, they're also bearing in mind, or they may be bearing in mind, that the external benefits, if you like, or costs to other people. So when you're analysing behaviour in public health, apart from it being very complex, health-seeking behaviour anyway, because people are trying to keep themselves well rather than make themselves, rather than recover from an illness. You're also thinking about these other external effects in a community as well, as also in addition to that. So that makes it, from an economist's point of view, that's how I interpret behavioural economics in a sense.
Okay, and so some of these, there's some big challenges now, aren't there, particularly around lifestyle factors, so whether that be smoking or alcohol consumption, obesity more generally, and the cost that they have to us as a society. One of the questions is, we've got people online, and please do feel free to tweet whilst you're online at hashtag KFOnline. One of the questions is, what is the role of different people in this sphere? So some people would say, okay, well, what's government's role? Is that around regulation and taxes, for example? What can people in local authorities be doing? What's the role of the NHS? And then this big debate we have around shared responsibility, personal responsibility in the individuals. Sam, coming to you, that question on, there's lots of different actors. We've already learnt it's complex, this area. What is the role of government in this area? What can government be doing to encourage some of these behaviours?
Yeah, sure. I think when it comes to behaviour change, it's clear we all have a role to play. I think that it can't be solved just by government or just by individuals. I think we need to be working together. In terms of the role for government, we should come on to talk about the role of legislation and regulation. But there's a few areas for action in terms of individual behaviours, which we know by looking at the data that we should be focusing on. You've mentioned a couple already, so that's very helpful. My top three, when you look at the data coming out of the Global Burden of Disease study, it points to healthy eating and nutrition as being the number one priority. So being overweight or obese is actually the main risk factor for a range of different health conditions. So that is absolutely essential. There's also the role of physical activity in staying active, including strength and balance exercises. And then the second main area is about smoking, in being smoke-free. Relatively few people smoke, it's 1 in 6 at the moment, which is one of the lowest rates in Europe. But still, we need to continue the decline. And just the third area to touch on is around mental health and well-being, which doesn't feature as clearly in the data, but we know it's important. And folks might have seen yesterday the Every Mind Matters campaign, which was launched, which is a really good step in the right direction in terms of what we can do for our mental health as well as our physical.
Katherine, the thing about campaigns, I mean, Sam's raised campaigns. I remember doing a piece of work a while ago around 5 a day, for example, and I remember doing a sort of evaluation of it. And actually we saw awareness had gone up, but consumption had gone down. So what role is awareness in this area, or do we need to be thinking more broadly around what we're trying to do?
Absolutely. Awareness is your sort of first port of call, really, making sure that a population, a group of people has knowledge and understanding of an issue so that they might be sparked to begin to pay attention to it and to consider changing action and behaviour. And for a certain proportion of any population, a little bit of knowledge and a little bit of information may well be enough to spark change in their actions and activities and behaviours. But there will always be a much more significant proportion of that population that needs more to happen in order to move them in the direction that we might want to see them travel. So it might be that they need more skills, it might be that they don't yet feel motivated enough to change that behaviour. As Tim already drew our attention to in some of the intro speak, capability, opportunity and motivation have been identified by a whole body of work coming out of UCL and Susan Mickey's team around the key drivers that we need to understand. And obviously if you can make sure people feel motivated, which isn't just about their knowledge and skills, but is also about their beliefs and so on, if you can give them opportunities and if you can, by changing environmental conditions, for example, and if you can provide them with capability or support capability development, those ought to be the conditions that you need in order to change behaviour more broadly in a population of people.
So what I'm getting at from that partly, Katherine, is that understanding, the understanding of why people behave in certain ways, that kind of insight into what's already happening. And so your work, Richard, on flu vaccination, what are some of the insights that we can draw from that in terms of why people are or are not taking up flu vaccination?
Well, I mean, the basic facts is that people are not taking up flu vaccinations as much as they ought to be in the adult years. I mean, we're not talking about we didn't look at the elderly, for example, over 65. We looked at the people between childhood and up to the age of 65. There is not the uptake that and engagement that we would expect to see, that we get from other immunisations and vaccinations. Of course, there is a background noise to all of this, which is that people are becoming slightly more sceptical about the whole vaccination and immunisation debate, and that's a sort of social-wide thing, and that's been borne out by a recent study by the Wellcome Trust. People not necessarily accepting the views of professionals and perhaps a little bit more so health professionals, but generally they're a bit more sceptical than they were. So we're finding that there's fewer people than we might expect who are fairly high risk when they do get flu, and they would be well advised to get a flu vaccination every year, and it has to be every year because the strains and so on change. But the reasons for that are multiple, and some of it is to do with what we call supply factors in economics, and some of it is to demand. So the supply is on what can the system offer people in order to make it easier for them to comply or get along and make that as an easier transaction as possible. And some of that is economic, and some of it's just behavioural changes and offering and logistical solutions, if you like.
Okay.
On the other side, you've got the demand which basically comes from someone's intuition about that the subject. Do they really want? They think it's important. They prioritise it over other things in their lives, and have they received the right information to interpret the risks?
Just back on that, that's really interesting because we've got a question here from Neil Donald, which is what role does fake news play in citizens' health decisions and actions, and how do the experts manage that discussion? So I'm going to leave you to ponder that one for a second, but anyone want to come in, because that's a really important question, isn't it, which is arguably this. I've certainly done some work with the public where there can be they can see conflicting evidence on red wine's good for you, red wine's bad for you, diet, these things. How do you, from a professional point of view, start to manage those types of discussions?
Let's start. Maybe one thing I just mentioned, there's quite a lot of interest around fake news in the behavioural insights community, I think, at the moment. I think there's some interesting ideas about how it leads to polarisation, and particularly how people things like, I think, affirmation bias, confirmation bias, people can sort of seek out and identify with news that supports what they're already thinking, which can sort of lead to sort of polarisation of positions within the sector. So if people are or do have concerns maybe about aspects of health, and then they see those things coming up, they may place more weight on that. They may that may reaffirm some of their thinking.
Okay, are there any other views from the panel on this? Because it is a really difficult area, isn't it, about health information, what you listen to, what you don't listen to.
I think with the sort of flu vaccination example in particular, you've got to feel quite strongly motivated to take the action required to turn up to an appointment and go through with that process. It's a much easier behaviour to not go to that appointment or not book that appointment in the first place. So the effect of, or the impact of, some messaging that will begin to sow some doubts into your motivation for doing that action or behaviour in the first place can be quite powerful quite quickly, I think, in changing somebody's decision to go to that flu vaccination appointment.
Yeah, I think, and on that's absolutely right. That people are on the balance, on the cusp, if you like, of making that cost-benefit decision, and and if they are slightly tilted toward against it, then the benefits, then the costs in their mind start to stack up. I don't mean monetary costs. I mean inconvenience costs and disruption costs of life. Day-to-day activities. If those can be minimised, then maybe it is made as simple as possible. In other words, the vaccination is put right under your nose or your arm, I suppose. If you put it, if you can make it as easy as possible to get someone into a vaccination chair, to have that needle, then that's probably going to overtake some of the scepticism that they probably otherwise carry around with them.
That's a really important principle, isn't it, in behaviour change, that making it easy, rather than is making sort of getting beyond the availability and actually, as you say, thinking about the logistical problems. One question from Matthew Lowther from NHS Health Scotland. You can see where that might be going with this one. The evidence clearly shows that more upstream interventions, such as the smoking ban and alcohol minimum unit pricing, and there's been a recent paper on this in the BMJ on what's happened in Scotland, is much more cost effective, will reduce health inequalities and are more likely to have a population impact. Does the panel agree with that? What is the role of these kind of upstream government interventions?
Shall I talk a bit about that as the government person? Yeah, upstream makes sense, doesn't it? It's quite logical, really. And I think in our own country, we know through the smoke-free legislation from 2007, had a huge impact on people's behaviours when it comes to smoking, in really normalising a new set of behaviours. What I would say is that there's a package of other interventions, though, which were wrapped around that as well. It wasn't done in isolation. You've got services for getting people smoke-free sort of ramping up, in some other sort of actions that individuals can take in campaigns and education. So I think the role of legislation and regulation has an important part to play, but it's about the package and how it all works together.
Okay, so it's not, so what I'm learning from that, it's not one thing in isolation. Is it a range? Is it different? Because smoking, there was a smoking ban, but smoking has had lots of different ways of approaching it, from awareness. Tim?
Yeah, I think, again, if people want to have a look at that behavioural and social science strategy, smoking was kind of one of the sort of case examples we used in there to try and really get across the aspect of a system around these behaviours. And so there's different aspects in terms of, there are different behaviours. There's behaviours of the public, there's behaviours of organisations, there's behaviours of healthcare professionals in terms of for brief advice, for example, around smoking. And we need to think about all of those. One of the things, I think one of the things that is a useful sort of concept to have if people are familiar with the Nuffield ladder of bioethics. So that sort of talks about the sort of regulation legislation being at the top. Maybe some of the most impactful aspects, but maybe sometimes some of the most controversial, and so they need sort of acceptability for the public behind it. It goes down sort of through more of the sort of nudge interventions in the middle, which are more about enabling behaviours, down through to sort of giving information at the bottom, which is potentially the least controversial, but is also potentially the least effective. And again, I think that we sort of think about that, and also around the behaviour change wheel, which is another way of thinking about different levers that you can pull in a system to sort of drive behaviour change. So legislation and regulation would be part of that, comms and marketing would be part of that, service provision would be part of that, guidelines, we produce a lot of guidelines for people out there to support them in their behaviours. All of these are part of a system that we need to deliver. I think one of the things I sort of looked at before I came thinking about smoking was that some of the taxes, I understand, when they were introduced didn't really have an effect on their own until they were used more in combination as a package of interventions.
Katherine, yes.
Yeah, I was just going to add that the person who asked the question, I think, mentioned cost effectiveness specifically, and I think that's quite an interesting aspect of it, because lots of the kind of legislative, broader governmental policy stuff is quite cost effective in terms of doesn't cost very much to implement and can, in combination with some other things, have quite a large effect, relatively speaking. And it sort of depends on what's your budget and where do your priorities sit as to how much you perhaps push with some of those legislative things relative to the more direct, costly, perhaps face-to-face interventions. So if you think about putting in, really good quality stop smoking services with well-trained staff, that's an expensive thing to do. But if you've got a real priority around trying to cut smoking, it's perhaps needed in combination with some of those kind of policy legislative actions in order to really drive change in particular communities, for example.
And you mentioned change in particular communities. One of the key questions on this is what place health inequalities? So we can talk about population change, but we also need to bear in mind from a public health perspective, health inequalities. What role this field within health inequalities? We know that some communities, whether it's life expectancy or prevalence of conditions, are more adversely affected than others. What role this field within that question of health inequalities? Sam?
Sure. Health inequalities, it's something that we talk a lot about in the Prevention Green Paper, which is all about trying to boost the amount of time people can live free of ill health and disability. So folks living in lower socioeconomic groups, we know that they tend to live shorter lives and actually spend a larger proportion in poor health, which is a travesty, basically. So we need to be using all of our policy levers that we've got available to change that. In behaviour change interventions is a really important part. What I would say, which I'm sure people want to add in on, is individual lifestyle changes is one aspect to it. Another really important part is what Marmot would call the wider determinants of health. Things like where people live, the jobs they do, some of their early year experiences in childhood, which we know have a huge difference in terms of people's future life chances. So I think in terms of behaviour change, we need to be thinking not just about what it is individuals could be doing, but what we as a wider society can do in order to give them the very best opportunities in order to live well in the future.
I've got a question here which I think is linked to a couple of points that we've made. One is around kind of ethics of this way of working. So it's the question, I suppose, is that, be interested to know the panel's views on the ethics of this way of working. We could nudge people not to smoke, or related to that question before, around government could ban smoking. Wouldn't that be more honest and less manipulative? And that is one of the challenges levelled at nudge work, is it's trying to sort of get people to do things in a slightly I'm not using this word, underhand way. What do we think about the sort of ethics of this way of working?
Maybe I better comment on that. I think in some of these areas, there's a number of different sort of positions put forward. It is a big discussion. There's a lot of conversation and discussion about the ethical aspects of all of these things. But I think equally with any kind of intervention that we're delivering, that we should be thinking carefully about the ethics. There's a number of things that come to mind. There's a useful framework called APPEASE, which is just an acronym which kind of thinks about the acceptability, the effectiveness, the safety, etc. of interventions. It's always useful to think through some of those things, the affordability as well, when we're thinking through what we're doing. Another aspect, and I come back to some of Theresa Marteau's work, I think published in Science, really looking at a number of different interventions, and for a long time in public health we've done things that could be more effective, possibly, and sometimes when we work, a lot of our interventions that work through giving information and sort of providing knowledge can actually increase health inequalities. So I think one of the potentials with a lot of the work around behavioural insights and that kind of approach, for the sort of psychologists, it's more about the automatic motivation and social opportunity. We're not using them enough in our interventions, but some of those things can make it easier for people to undertake healthy behaviours, and so you can actually kind of try to even out some of those health inequalities through these approaches.
Other views on that kind of ethical question?
So in the work that I typically do, we are often looking at what are the particular psychological barriers that somebody might face around their motivation and their capability to engage in a particular health behaviour. Quite often that's a health behaviour that somebody actually wants to engage in, wants to perform. So they want to have safer sex and use condoms, for example. They want to eat a healthier diet. They want to get more exercise, but they're not necessarily managing to do that effectively. You know, day-to-day life, your habits, the kind of cultural norms, the social norms might all be against you in achieving something that you want to do. And typically what we're doing when we're developing interventions is exploring that range of barriers that the target population is experiencing and thinking about strategies, particular bits of content, objects we might add to the environment, social support, whatever it might be, that would address those barriers quite specifically. And so we're not doing it to people, we're often doing this in partnership with groups, with individuals, with communities, in collaboration. They're involved in devising the content of what we're coming up with, and hopefully it's ultimately something that's really what they want and is really supportive and gets them closer to their own goals. So not in any way unethical, we would hope.
So what you're saying there, I think, is it's in line with someone's desired behaviour anyway, and you're trying to ease that rather than go sort of contrary to what people are trying to do.
Yeah,
absolutely.
Okay.
We may come back to that public acceptability argument because I think it's a really interesting one. Just, you mentioned collaboration. So Kitty Grew from Islington CCG says, where does integrated care fit into this? So the collaboration between the government, NHS, public health, etc. If these groups work in silos, can this theory still be effective? So I think that's a really important question around public health and the NHS and how you start to bridge that. Again, Richard, I think on that flu vaccination work, did you see, because you've got different actors in that, haven't you? Where have you seen it be effective, and what can people do to improve where it isn't?
Well, integrating, we didn't actually address the local authority part of the jigsaw, but it would seem that there was a kind of something missing in the whole debate about when we spoke to the NHS teams that we spoke to, that really there could have been yet another layer of support that was offered by the local authorities, and in terms of encouraging people, advertising flu vaccinations, or the opportunities when they presented themselves to their staff to also nudge, if you like to use that word, or suggest to people, offer people the opportunity that they could take that service up from the NHS, because it's predominantly led, as you know, by GPs in primary care and their staff. But there's so much interaction in a practice between social care, social services and primary care, that there seems to be another discussion that needs to be had, and your questioner is quite correct that that does need to be integrated and borne in mind, but I'm not sure that we addressed it in our particular study very well.
Other people, this integration question.
Sure, shall I chip in? Yeah, integration, the government's been working about trying to integrate health and social care for a while now. Again, that is quite a logical approach to take. In terms of prevention, we know it's really important. I mean, what I would add into that mix as well is housing. We know home adaptations are essential for keeping folks independent in the community. So I think it's not just, I think there's often a debate about health and social care, but for me it's a triangle with housing at the real central position in there. And just the other bit I'd add as well is about the role of care and support for people. So often folks have lower level support needs, which if they're not met effectively can develop into a health or a care need. So really it's almost like an escalator. So if we can get some of those basics right, where there's a role, there's obviously the role for community groups there and friends and family. So I think it's important to take a really holistic view and not focus too much on just the service element.
Yeah, we've just been doing a piece of work looking at the Wigan deal and what they've been doing out there. And that raised for me, as you were answering that question, the role of community and that kind of partnership working. Any thoughts on that? Yes, it's government, it's services, it's individual, but are we missing something there around what is that community role in some of this work?
I was going to say, over the years we've done quite a few pieces of work that would be community-based or draw on members of the community. And you often find when you work in that way, kind of key assets, people in those communities who are held in quite high esteem by a large number of people. And they can be really supportive mechanisms for reaching people who you might not otherwise find and get to, and for devising really acceptable strategies that get taken up by community groups and so on going forward. So it's been a really productive way of working for us.
Yeah, we found that with our study that there was in Manchester, we came across a flu champion who was a public health doctor who was basically held in very high esteem because of his work directly with the GP practices and his ability to facilitate information and share knowledge with people on the ground, and they found that absolutely fantastic. I have to say he was so stretched and so busy we never actually got to talk to him. That's how much he was in demand. But people kept telling us that without this guy, sort of being the glue in the system, that things would probably fall apart.
One more thing, it's a useful point to maybe highlight the aspects of sort of participatory development or co-creation of interventions with people. I mean, again, and going back to aspects of the ethics and the acceptability, if we can really work with whoever's we're working for in that process, then I think that has so many benefits in terms of both the effectiveness, the acceptability, and the engagement of those users.
Question here from Javier Caballero, which I think really gets me onto that kind of what works question. So as a rule of thumb, what proportion of people subject to a behaviour change intervention actually change their behaviour? So that might be tricky to answer. Does it last, which I think is a really important question. How, is this you do it and then it's done? How can intervening bodies know about how to maximise both of those aspects? So can I add a question to that, which is, practically, can you think of a behaviour change intervention where you can tell us what the effect of it was and a little bit about it, just to root it in the practical? So something where, and Tim, I know in the pre-discussion we've had, there's a number of different areas. There's sort of the work with doctors prescribing antibiotics. There's work that behavioural change has done about DNAs. Any examples you can give us? Because I think that what proportion is a tricky question, a sort of general, but can you give us specific examples about things that you've been involved in that have worked?
There's a lot of questions there.
Let's break them down. Give me an example of something that's worked.
I'll talk about something that that we've done a little while ago, but we've really seen some of the impact more recently. I'm not quite sure. I'll try and think about the questions and answer some of those questions. But it's around cervical screening, and we know that I've got some of the figures in front of me just so to help. But we know that around 4,500 lives can be saved annually in the country through cervical screening, and if all eligible women participated, 83% of cervical cancer deaths could be avoided. So there's a huge potential for improvement there. We know that in some areas uptake is not as high as it can be. Probably going back to what Katherine was saying, probably a lot of women would probably have good intentions about going sometimes. And so what could we do to help? So this is more of a nudge kind of intervention rather than a more complex intervention here. But basically what we identified was an opportunity to send SMS text reminders to people. So they'd already received a letter and invitation. They maybe had kind of had good intentions to go. And what we wanted was to provide some additional support to that. So what we did was we basically sent different types of text messages and different content of those messages to try and see what would work the most. And basically we saw around a sort of 4 to 5% increase in the uptake of cervical screening amongst women. The most effective, most useful message was around the endorsement from the GP, the sort of a credible messenger. It was very interesting, I think, to see more recently. We did that in a borough in London, and more recently it's been rolled out across London. And in around, I think it was a 9-month period, we think if we follow we saw about a similar increase in uptake in cervical screening. But if you think about that across that whole period, there's an estimated almost 13,000 women screened for having a cervical screen. So we know still that's not everybody in terms of the question, in terms of who changes their behaviour. But often some of these marginal gains of 5% actually for very low cost, and I think this is the benefit of some of the nudge interventions, if we could get that kind of improvement level across the whole of the NHS, a 5% increase at very low cost, that would be huge. Yeah. So they have these types of interventions and really have their place, I think.
Great, that's really helpful.
I'm not quite sure how many of the questions I answered.
I think it was a tough question, the question was what percentage of people on behaviour change interventions, which I thought that's why it's helpful to get those individual examples, isn't it? Yeah. To see, okay, well maybe it's small changes, but actually when you take that and you generalise it to the population, you could be looking at quite big differences.
It's about 4 or 5%, but relatively it was about a 20% increase in the proportion of women having their screening.
Catherine, any examples that you would like to make people aware of?
Well, in relation to how much the population changes, it does depend on the behaviour as to how effective the intervention tends to be. And for some behaviour change interventions, the effect size is quite small. But just as Tim was saying, sometimes in a population, that kind of small change actually equates to quite big numbers at a population level, and kind of clinical effectiveness is sort of achieved in terms of a change. I think in terms of evidence about what works, there's lots of evidence around things like the screening invitations, invites for vaccinations and so on, which shows that if you just change wording in letters so that the way the message is conveyed in that kind of brief intervention of an invitation to come to something, that can really have quite a large effect in terms of the uptake of the screening or the vaccination and so on. When it comes to more complex behaviour change, so when we're looking at increasing physical activity, which has to be begun and then maintained over a period of time, I think the evidence base is quite strong now around the sorts of components that might need to be included in what we would call tier 2 physical activity behaviour change interventions, about the types of content, the types of strategies and techniques that need to be in those programmes to help them to be effective. So goal setting, which is properly managed, so people set realistic goals about what they're going to achieve, for example, providing them with really good feedback on how things have gone over the course of a week or since a last session. Those kinds of things are effective strategies in those interventions. And there is some good evidence that the effects in terms of actual weight loss can last quite a long time. So studies tend to only typically measure up to about 12 months post-intervention, but there is some good data on effective interventions up to 12 months now.
And you made a distinction there between things like trying to get someone to a flu vaccination or to a screening versus some of those more potentially complex areas like someone doing more physical activity. Is that a useful distinction for people listening to draw between a sort of health-seeking behaviour and some of the more complex issues? Richard, is that something that we should I know your work around the flu vaccination was
I think it's a
specifically
fair,
about-
yeah, I think it's a fair distinction to make. I mean, there are things which are sort of one-to-one ratios. I mean, we know that vaccinations and immunisations on the whole work, given a certain coverage of the population. And they're kind of, in a sense, simpler technologies. I don't want to denigrate the complexity of those, but they are simpler than some of the behavioural change interventions that we've been talking about, like physical activity and obesity. Smoking is another one, alcohol consumption, mental health. These are, areas where you can make some impact to some effect size for a short, well, it's measured from over a relatively short period in the studies. And one would presume that those need regular top-ups of the initial intervention, or at least some part of it to maintain that motivation or maintain that behaviour. Because we all know we make good resolutions on New Year's Day, but how many of us keep them by the 1st of June? And so that it's a human trait to dismiss the bad things and bring forward the good things in our psyche. So I would say, yeah, we have to temper it by those two the distinctions you just made there, Dan. Yeah.
Yeah, Sam.
Just to build on that really, so I think with those more complex behaviours, something we've not talked too much about is how you can build people's basic resilience, which is not specific, whether it's smoking or weight loss, it doesn't matter. And this is something the new NHS Alliance talks a lot about. They talk about the 3 Cs. I'm going to forget one now that I've listed the 3. So they talk about folks feeling in control of their lives. Is the first one. They talk about people having the confidence, which is the second, in order to make those changes. And then the third one is contact with other people. So having that sense of purpose and the contacts to do that, whether it's friends or family or work, which I think is really important, because without those building blocks and that strong sense of personal resilience, am I going to continue making changes in terms of smoking cessation or weight loss? Probably not. And if we're interested in long-term impact, then I think it's really beneficial to think about supporting people's self-efficacy skills across the piece.
Yeah, Tim.
Is that okay if I come in? Because I wanted just to highlight, I mean, we've talked a lot about individuals and the public behaviours, and we did sort of allude to it earlier around the influence. There's a broader system that is influencing people's behaviours, and health professionals have a role to play. Maybe the emergency services, maybe the wider sector. But I also, I think maybe it's an important or relevant time to sort of raise aspects about sort of the environmental cues that we respond to, and particularly you were talking about something like obesity, so the sort of obesogenic environment in which we live. And so I thought it may be a good time just to mention we've done some work in a number of hospitals when we were talking about with NHS England about a sequin, an incentive for hospitals and secondary care to improve the environment in which people live and work. And so we did some work with a number of different food environments. So this is rather than that sort of more cognitive kind of influence and that kind of things we've been talking about, but we did things in a number of environments, like moving crisps and confectionery sort of towards the back, and moving the sort of fruit and vegetables or water to the front, and having sort of 2-for-1 offers on water, and a number of different interventions. We did also some work in vending machines with Leeds Teaching NHS Trust. And so thinking about that environment and how we can change those, I think we definitely saw changes, was one thing that's really coming out of it. So these things do work and do change people's behaviour, and they don't need to think about it every day. They don't need to make that sort of use their cognitive load, the kind of reflective thinking that they might need to go to, and the kind of resilience that they might need to kind of address some of those behaviours. But we can make those changes. But I think one of the important things out of that we showed was that actually the levels of sales were fairly stable. So there wasn't a big hit, because if we're going to encourage private sector organisations to kind of make some of these changes, then we have to think about what are the levers for that. And if we can show that their customers want a healthier offering, but also that that doesn't mean a hit particularly in terms of their financial viability, then we've got a kind of a win-win situation.
It's back to the point of various different actors there.
Yes.
I've got a few questions actually on a similar theme, which is around digital and technology and the role that that could start to play. I know, Katherine, this is sort of an area that you've done some work in. So I suppose, should we be investing more in some of those digital interventions?
There's certainly a really important role for the sort of digital world to play in what we do in this sphere. It presents really strong opportunities to us. So one of the sort of benefits of using digital content is that you get massive potential reach out to sectors and populations you might not otherwise be able to easily reach. You can also achieve really strong fidelity of what you're doing, so you can be really sure about consistency. There's also some really nice opportunities for tailoring content dependent on how somebody interacts with digital technology, and again being quite consistent about the messages you might be giving to people through that tailoring process. So yeah, tons of opportunities. One of the things that I think is really important about potential use of digital is looking for where people are already engaging in the digital sphere in a way that's relevant to their health, and then making use of that to reach populations. So a piece of work that we're about to start is a digital intervention. It has non-digital components to it as well, but it sits in the chlamydia self-screening care pathway. So more and more local authorities across the UK are using online methods to get young people, where STI rates are highest, to order their self-screening tests, and then they get the results and so on online. But there's very little health promotion going on in that care pathway typically until somebody is diagnosed with an STI and has to come into contact with the healthcare services. So there's lots of opportunity to give condom promotion, information, campaign and messaging and so on through that care pathway. And people are quite engaged with the idea that they might want to start using condoms more consistently if they're thinking that they might have an STI. So it's a really good opportunity to reach that population, and one we should take advantage of.
So the sort of digital component in terms of where the government is on that, what's your views on what could be done in that sphere?
Yeah, sure. Agree with what Katherine was saying totally. I think the idea of being able to tailor your messaging depending on what we know about people is really exciting, and I think that will be the future. And also actually directing messages away from people where it's not needed. So if I'm a smoker, then target me with your social media messages on smoking support. If I'm not, then please don't bother me actually. So I think there's opportunities there. Just talking about digital, I just wanted to broaden our focus too. There's a space around digital policy making, which is less about apps or services and more about an approach. And actually there's quite a lot of crossover with some of the behavioural science approaches. If you talk to digital people, they are obsessed with the user. Who is the user? What are their needs? And they will test products with people and iterate them. And actually I think some of that approach, it's what behavioural science is based around, isn't it? Really understanding the behaviour, coming up with a diagnosis, and then building your intervention around that and testing it. So when it comes to digital, I'm excited about the technology, but I'm also excited about the approach and how we can bring it into what we're doing in health.
Tim.
Yeah, there's a number of things, if I try and be relatively concise, but we're doing some work exactly right now trying to look at the sort of behavioural science approach and the digital approaches and how we can bring them together to get some of the behavioural science theory and evidence built into some of these apps. We know in a number of areas that digital products are not always very effective and don't often or don't always include all of the kind of behavioural techniques that they could use, so they could be much more effective. We've done a piece of work at the moment looking at digital interventions in sort of cardiovascular disease in sort of middle age. We presented a poster at the PHE conference and sort of will be submitting the publication relatively soon, but so systematic review looking at sort of digital interventions for smoking, alcohol, diet and physical activity. And I think it's interesting, I mean, what we see is a relatively small effects, but sort of, again, as we were talking about earlier, on a population scale, and particularly, you know, so if you have a relatively affordable intervention that you can deliver at scale that reaches people, as our Duncan Selby, our Chief Executive, taught, you know, where they're living in their lives and how they want to use it, then you've got a really powerful intervention. We do know that people tend to disengage from apps quite quickly. So the aspects of engagement we're doing, the sector is learning a lot more about how people engage with digital apps. And one of the things, again going about the quality of the products out there, there's some work that we've done previously developing a digital assessment questionnaire. So it enables us to look at some of the quality of the apps and be able to endorse or promote apps that have gone through a fairly rigorous process, so that people can have confidence in, because I think aspects of trust, whether it's data or whether it's more in the kind of effectiveness of an app or a digital intervention, are really important. So it's really important if we can try and find ways to kind of give people confidence in the digital products that they're using.
There's a question, yes.
No, I was just going to add to that. Sorry, I think if it's endorsed, I think if digital technology is endorsed by professionals, then I think that helps to get traction on its use and maintain. I'm not saying that it's exclusively the domain of professionals to recommend these things. It certainly isn't. But when it comes with a package where you are, also being told of the benefits. For example, we did some work on prenatal screening in one London hospital, and it was a simple app really for women to monitor their blood pressure in pregnancy, and that came with the incentivisation. They don't have to turn up to outpatient clinics routinely just for the routine checks. If there's nothing patently seemingly going wrong, they could monitor that themselves and only come if it's necessary. It's kind of quite a simple concept, but it was put through a digital platform. Likewise, we've done some work on a digital app that allows people to monitor their heart rate, their ECG essentially. So for looking at arrhythmias in heart disease, and people can access that now at the pharmacy, or some pharmacies are providing this. You just put your fingers on a little pad and it will give you the readout, and the pharmacist can interpret that and advise you likewise. I think if it comes in a package of some kind of sort of service, then it just doesn't disappear into this vanilla world of digitization and just mind-blowing number of apps that are out there that people then just don't really know how to choose and use properly.
The question here from Rachel Kirkwood, which is, we talked about wording in letters, for example. Do you have any examples of advice for what type of wording works better than others? So I suppose that led me to a question about, how do you know? So I think how do you start to work out what that wording is? Do you start with where people are? What's the process? What should people be doing to get to that type of intervention?
I mean, the first thing that we would typically do is really try to understand what the barriers are for that particular target population, and then try and make sure that you've got clear, you don't want to bombard people with too much information. It's got to be quite clear, got to be quite specific, but it just really targets the particular issues that population's experiencing.
Yeah, okay.
I think there's some more generic evidence about chunking information so it doesn't just overload people from the sort of nudge side of things, behavioural economics side of things, and tailoring the letters very much to that person, so using their name in it, for example, rather than a generic dear patient type letter. Those kinds of quite simple ideas as well.
So there are things that we know already, are there? That personalisation, is the keeping it relatively simple. So I remember, there's been lots of debate on the cervical screening letter. Do you use the word smear test? Do you use cervical screening? Do you talk about specificity? What do? Do you start with the user and then work backwards, or do you have some ideas going in?
Yeah, I don't know. As Katherine said, I think if you can work with users and understand their barriers. So, I mean, where we start normally is what's the behaviour we want to change. And we talked a little bit about what is a behaviour. So behaviour is something you can see people do. So if it's attending an appointment, and there's lots of different sort of prevention sort of associated appointments that people need to attend, whether it's vaccination or screening or cardiovascular appointments, there's something they need to do. They need to often it's first thing they need to do is call up and make a booking. So it's thinking about what is that behaviour, being very clear about that, and thinking about what is that outcome, and then if we can work with the users and sort of co-create some things in terms of what's acceptable in terms of the language. I think that's, sometimes we can use words that really put people off and disassociate people. That's quite important. But and then there's the sort of the scientific knowledge. So we know from sort of synthesizing literature what might work what's worked in other cases, and we have the sort of theory that can inform us as well if we're kind of moving into areas where we don't have exact, we can't replicate directly from another area. So those are, it's a number of different things. There's a relatively simple framework which people might be familiar with, which might be useful if you haven't heard of, the EAST framework, which stands for easy, attractive, social and timely. And there's more detail behind that, but some of these simple things people can think through can be really helpful.
I think there's been some evidence that if you just give people an appointment and they only need to be in touch if they're not going to come to that appointment, then that can drive effective attendance at appointments. And simple text messages as well to remind people to attend. That's been brilliant in reducing DNA rates in sort of GP surgeries and other settings.
Yeah, we found that with the flu study, that the text message was a very effective means of getting people into the surgery for it.
I'm going to wrap up soon, we've got about 5 minutes left, but it's testing, isn't it? I think one of the things I've learned is you're testing and what works with people and adapting as you go along. So it doesn't, I think one of the messages I've got is it isn't you do an intervention and that's it. You're constantly trying to work with people to refine and improve where you can.
Yeah. There's a really important role of evaluation, experimentation in all of this, I think, to identify what works. And just highlighting that aspect of what works for one behaviour in one context might not work for another behaviour in another context, but we can take some of the learning, but we'd ideally want to sort of test it out a little bit, always in a proportionate way of doing that.
Great. So just in the last 5 minutes, I think there's lots of things that I've kind of picked up, which is partly the complexity of this area, which you've got to at least sort of be aware of and address, and that idea of collaboration between different organisations that play in this and understanding the role of each. I've certainly learned something about the importance of testing and working with users or whoever your group is to start with that and the behaviour that you're trying to, and at least understand. Something really important about understanding. So people listening in, is there anything just to go around the panel, just to sort of last thoughts in this area, really thinking about what can people do working particularly in local systems? What would be the key piece of advice? So start with Tim.
Yeah, I'd really like to let people know about the Behavioural Science and Public Health Network.
Yeah.
So Public Health England's been working with that network, and we've really started to kind of create communities of practice at sort of local, regional areas of the country. So do look up BSPHN.
Let's just repeat that.
BSPHN, Behavioural Science Public Health Network.
Great.
If you look up and get in touch, you can probably find out something that's happening in your area or kick something off in your area if there's nothing happening. But really trying to enable some networking and access to tools and resources so people can really take some of this and use it locally.
That's a really helpful point, isn't it? Because there's so much that's already known.
Yeah.
It's not starting from scratch every time. Great, thank you. Richard, any points?
Well, I think the point that I've learned from the research that we did on flu was that there is no one magic silver bullet, and there probably isn't in any public health field that you focus on. I think it's all complementary. You do need a multi-vision approach to a component approach to actually make something work. I mean, we've seen this with the reduction in smoking and other areas in public health. Earlier question about top-down taxation versus bottom-up behavioural change. It all needs to be part of the jigsaw, part of the solution. Public health needs, if you come at it like that, then eventually people kind of take on their own message from whatever angle they feel comfortable with. But trying to address a problem with a single, silver bullet is probably futile in the end. So what I've taken away from flu is that carry on doing those things, but also carry on rejigging and rethinking those in that evaluation cycle that Tim mentioned from year to year, because you'll get better at it.
That's really helpful. Again, feels like there's a message there again about the collaboration, about all the players within an area, and really getting that shared understanding of where you're trying to get to.
It's not a one-time opportunity. You can keep doing this and refine it and get better at it.
Great, thank you. Sam?
Yeah, I'd reflect, I think it's an exciting time, isn't it, for behaviour change at the moment, and there's a lot going on, emerging evidence. Just a bit like Tim's plug, I'd plug the Prevention Green Paper. So it's a consultation, and there is behaviour change throughout the 3 chapters of that, across the behaviours, across the wider determinants, and across the services that people use. So we're just coming to the end of the 3-month consultation. If you're watching this live, we've got just under a week left before it closes. It closes on Monday the 14th. So if you haven't done so and you've got strong views on this, please get in touch with us. It's a really easy to find webpage. Just Google Advancing Our Health Consultation, and there's a fab webpage to use there to answer questions.
Great, thanks Sam. Katherine?
Yeah, just a couple of things from me. I would say that if you're new to use of behavioural science, you're wanting to bring it into your practice in public health or wherever else, and you're feeling a bit trepidatious about that, reach out to the BSPHN, as Tim mentioned, or to a local university where you may have behavioural scientists, social scientists working who might be willing to engage with you. Certainly I've been working as an academic in that way for a number of years, and it's a really great collaborative experience. So I'd really recommend people do that. The other thing I want to just, because I don't think we brought it out too much in the discussions, we quite often get asked about wider determinants. It was Marmot review and so on was mentioned earlier, and people say, but what about that? How does behaviour change, behavioural science fit with that agenda? And I think the key point to make is that it's not an either or situation. We need to continue to work on reducing poverty, reducing inequalities generally, improving education, improving housing, all that kind of contextual stuff, the environments in which people live. And in that context where those things are optimised, behavioural science will flourish and will help us to achieve some of the other things that those things on their own won't do.
Great. Tim, you want to come again?
Yeah, so I just wanted to mention one other thing that people might find really useful. So the Local Government Association has a call for behavioural insights projects. So people can work in partnership, get some resource and do some kind of intervention and evaluate it locally. So do have a look at the Local Government Association website around behavioural insights.
Great, thank you. So thank you very much to the panel, really, really helpful, lots in there. Thank you very much to everyone that's taken the time to watch today. We certainly at the King's Fund are really interested in this area, and I think we're doing some thinking around that kind of tax and regulation question. Thank you very much. That's the end. Thank you.